Hey everybody, welcome to today's Lunch and Learn. Stand up to hip pain. I'm Randy Withers with the marketing department. Thanks for joining us today. Hip pain can leave you feeling low down. It's a common problem with many causes. Our expert speaker today is Dr. John Eggers, an orthopedic surgeon with Orthopedic Health of Kansas City. Dr. Eggers will discuss the hip's anatomy, different causes of pain, non-surgical and surgical treatments, and rehab with physical therapy to help reduce inflammation and improve hip strength after surgery. Board certified in orthopedic surgery, Dr. Eggers earned his combined medical and postdoctoral degrees from the University of Nebraska. He completed his residency in orthopedic surgery at the University of Missouri, Kansas City. Dr. Eggers subsequently did his fellowship training in hip and knee surgery at the Cleveland Clinic. He specializes in hip and knee preservation, total hip and knee replacements, and total joint revisions. If you have any questions about our topic today, please be sure and submit them using the Q&A button below. We'll respond at the end of this presentation. And now please join me in welcoming Dr. Eggers.
Thank you very much for having me. Hello, and thank you everyone for joining us. Today's topic is going to be standing up to hip pain. The goal of today's talk is going to be multifold, but before we get into that, go ahead and just give a few disclosures. Now, as was mentioned, I am board certified in orthopedics. I am a member of the Academy of the Hip and Knee Surgeons. I am a reviewer for the Journal of Arthroplasty, which is joint replacements. I am a reviewer for the Journal of Knee Surgery, and I'm a stockholder in ROM3, which helps folks rehab after surgery. Now, it's very important to understand that these are only the perceptions and the beliefs of one person. I, unfortunately, as much as I'd like to believe and my children to believe, do not know everything. So always remember that too. All right, now for my background, I was at a boarding school for high school. I went to SLU, St. Louis U for undergrad, and then the combined degree at Nebraska, and then came here to UMKC for residency, went to Cleveland for some specialization. Now I've been fortunate to be part of Orthopedic Health of Kansas City for quite some time. Interestingly, I was doing a talk a couple months ago as well, and I kind of said, where's my expertise? Where's my knowledge at in all of this? And of course, my background is extremely helpful. When you are in training until the age of 37, you're like, wow, that's a long time. And then you find out how much more you learn after that. And so cumulatively, I've figured out over the course of my career since fellowship, I've seen about 35,000 patients, and that's in addition to all of the other previous, 14 years of postgraduate education. So the overview of today's talk. We're going to talk about hip anatomy. It's very helpful to understand the background behind what then can cause pain generators, what our treatment can be, going to a certain type of treatment being hip replacement, which is very common in today's world, the types of hip replacements, the direction to the hip replacement, and of course the post-operative care as well. Now, this is a lot of information. So my goal is not for you to say, I need to be able to pass my medical school anatomy class or my orthopedic surgical exam, but to understand the overview, the general picture, the aerial view. And so when we look at the hip and pelvic bone anatomy, what you can see here is all of those different areas point to different areas. Each one of those is a bony prominence that likely was created secondary to muscular attachments. Why is all of this important? Well, even if you don't have hip pain, if you have back pain, if you have shoulder pain, something you probably discovered is that you can have pain outside of just the joint. And each one of these different areas, each one of these different prominences on this pelvic bone anatomy is a different area where one of these muscles listed here may have come from. And this will be very important as we move forward, looking at both what's inside the hip, or called intra-articular, being that which is focused on with the hip replacement and hip treatment, and the muscular pain around that, which is often improved with things like physical therapy that we'll cover here in a while. So, hip pain generators. Now, I got a little bit of a preview into this. And what you can see here is on our hip pain generators, we have the non-joint pain side. So before you run and try and read all of this very quickly, we'll go through them together. On the non-joint pain side, what you want to realize is the joint is like a ball and socket for the hip. So that's a very specific area. The area surrounding that, though, the muscles, the abdomen, ligaments, tendons, back, hernias, and pelvis, all can produce pain in the hip area, which may seem overlapping and confusing at times. But then on the joint pain side, you can have things that begin to cause you quite a bit of difficulty, like arthritis, labral tears, a very fancy ligament called the ligamentum teres. You can also have issues with blood supply, which is what avascular necrosis is, or a fracture if you've had an injury. And some of the things that you'll find is that when does your pain come on? And sometimes you'll have to go to specialists to figure this out. But additionally so, it may be that the joint pain is when you move your hip, getting in and out of a car, getting dressed. Those are often things that can be an indicative that this is actually coming from within your hip joint itself. So treatment. How do we begin the treatment for such a complex problem? Well, we have some things that go from very early in what I call the invasive or medical treatment to then the more advanced. And so on the non-pharmacologic side, not providing any medications or anything like that, some very great things that are out there are things like physical therapy. So for all of the issues as far as the muscular pain, for even some of the ligament pain, tenderness, physical therapy is a really excellent option. And there are multiple options that we have here with the Meritas at these different locations that can help out in optimizing these different issues. Sometimes just having a cane to help reduce the stress onto the lower extremities can be great. Now, if you've ever been one of those, hopefully fortunate, 35,000 folks that have come to see me, you'll hear me often very happily and exuberantly promote water therapy and water aerobics. Really fantastic for movement and mobility, also offered here at the hospital. Weight loss is great. Significantly reduces the force across the joints. Low impact exercise, and heat or ice. Now, this is the non-pharmacologic side, and as we become a little bit more involved, we can go into the pharmacological side. With the pharmacology component to it, sometimes what you'll find is that people that are appropriate may be able to try things like non-steroidal anti-inflammatories, such as ibuprofen or Aleve. Tylenol, of course, is another one, acetaminophen. Some folks will go into herbal supplements. Now, with herbal supplements, you do need to be careful and watch out for the indications very carefully, as those are not nearly as well monitored as the medications that we get from the pharmacy, such as Tylenol or prescriptions. And then, of course, there's topical analgesics. There's creams out there, diclofenac or Voltaren, which recently came over the counter, lidocaine patches, and Blue Emu seems to be a favorite among many of my patients. Now, additional treatment for this. Least invasive to most invasive. Part of things like physical therapy, you can do fancy treatment like ionophoresis, where you actually use a current to stimulate medication administration into the muscles and soft tissue to help relieve the inflammation and pain. Dry needling is a more frequent one that's come up, which is pros and cons and needs to be very carefully given to a specific patient population for the right reasons. Sometimes you may hear people having injections as well. Some of those can be bursal, joint, trigger point. There's different types of injections, steroid, non-steroidal, biologic. And so one things to know about these various things, like our injections, is you want to be careful. So there's a lot of hype out there these days about doing biologic agents. Perhaps your PRP, your stem cells, things like that. And you do want to be very careful, because one of the things you want to focus on is what the evidence is, and not something that I'd ever expect anybody in the audience to be overwhelmingly knowledgeable, but the practitioner you're seeing does need to be knowledgeable. And you want to do the things that have been well shown to be beneficial for you. You'll find many different advertisements and things out there encouraging stem cells and making new cartilage, or PRP, which is platelet-rich plasma, to try and be the next kind of thing to help you avoid surgery. And by no means am I promoting surgery or otherwise, because there's so many other options as we've discussed so far. But I do want people to be aware that if you're paying $2,000 to $8,000 for some of these things, there's not a lot of literature to support them in many, or any, venue at all for the treatment of many of the hip conditions we've talked about so far. And so just as a warning to our audience, make sure that you have a complete knowledge and evaluation before you go into this kind of treatment for it. Now, of course, we've talked about a lot of things at this point in time. We've talked about physical therapy. We've talked about medications. However, at the end, if it involves the hip replacement or involves the hip joint itself, if you have tried these different treatments, you're not getting the relief you want, and you come to the point is, am I a candidate for a hip replacement? Well, it needs to be for the right reason. And so some of these things in a total hip arthroplasty, understanding what is the intent behind it. How does it compare to the native joint, meaning what you're born with? What does it accomplish? What doesn't it accomplish? And all of these are very important things. And so the intent of a hip replacement is to be able to repair the hip joint. And so when we earlier spoke of that which was within the hip joint and outside of the hip joint for joint pain, the arthroplasty is intended to fix the joint pain coming from within. So fixing your arthritis and other things. How does it compare to a native joint? Thankfully, over time, we're at the point in technology and advancement that our hip replacement is pretty close to the native hip itself as far as its functionality for being a ball and socket, and works extremely well. Lasts a very long time. What does it accomplish? Well, done correctly, it will resolve the issues of the problem within the hip joint itself. So a hip replacement is designed to eliminate that arthritis, get rid of the torn labrum, fix anything like the tear in the ligament of teres, resolve a hip fracture, fix the avascular necrosis, all of those things. But more importantly, what doesn't it accomplish? Well, one thing I should mention in what it does accomplish is that it reduces the inflammation from the problem within a hip joint. But what doesn't it accomplish? It doesn't replace the muscles. It doesn't replace the ligaments. What it does is it allows the inflammation to be reduced to be able to heal those. So, what are the indications for the hip arthroplasty? Well, some of the most common ones, and don't misunderstand, this is not all-inclusive, but the most common, would be that for arthritis. And what's arthritis? Arthritis is when we lose cartilage on the end of the joint. So as I love to tell everybody, what we all know, the white on the end of a chicken bone is actually the cartilage. That's what we have too. And when that goes away, that's actually what arthritis is. And the problem becomes is that the bone underneath that becomes very sensitive and painful because it's not meant to bear the weight directly onto it. Fracture, of course, the avascular necrosis, ligament of teres, and then non-repairable labral tears at the highlight. But why is it important that we follow these indications for a hip replacement when you're being evaluated, when you're being seen for your hip? Because as you've seen, there's many different pain generators I've shown you so far in just this short interval. Because if you have a hip replacement, and it's not for one of the problems you see here, you may end up like our dear friend here from the far side who says they're not exactly pleased with their hip replacement. And the reason for that being is that if it's not done for the right reasons, you're probably not going to be super happy about it. The other thing too is that the hip replacement resolves the issues within the hip joint. And I bring this back up for the hip anatomy. So once again, you can see all of the red, all of the blue, those are where muscles start and where they go. Well, they're overlapping the hip joint, which means they share the nerves from the hip as well. So the hip replacement will take care of the problems inside of the joint, but around the joint, we need other things. And that is what will come in to things like physical therapy, treatment, stretching, and reducing inflammation in those areas. But also, those areas can all be inflamed and painful without actually having a problem within the hip joint. The hip replacement itself, well, what you can see here is this is actually a diagram of a hip replacement. The most common hip replacement at this point in time is a metal shell that goes within the pelvis, a plastic liner inside of that, and then a head on a stem with the stem going into the femur itself, most commonly growing into the femur, which then articulates. And thankfully, at this point in time, if you use the right implants, they probably last for about 150 to 180 years based off our recent technological advancements. But it will also be important for those of you considering a hip replacement that you ask a very important question. What parts am I getting? Because what you want to make sure is you're getting the optimal parts, because there are different companies out there with different parts, and some work much better than others. Now, hip arthritis before and after the hip replacement. Something you'll see here, and you can see a template for a hip replacement here, what you'll see is there's no space. If you actually look at the figure on the left, you'll see there's no space between what should be a ball and the socket. The figure on the right is the hip replacement put in there after surgery, and also you can see on the right hip how there's actually a space in that ball and socket, whereas on the left hip there's not, indicative of what people might call bone-on-bone arthritis, which is pretty painful. Now, as we continue through the total hip arthroplasty components and approaches. So approaches to the hip replacement. There's many different forms to it, and I'm sure everybody has heard that this is the best or that is the best. Anterior versus posterior versus anterior lateral. And there's all kinds of indications for one versus the other. There's preoperative factors, there's size, there's anatomy. What's the problem? Are there other associated problems? Does something else need to be fixed that might be better seen at the time of the hip replacement in addition to the problem within the hip joint itself? Now, rehab after a total hip replacement. Extremely important. The healing components of rehab. You want to minimize inflammation, and we'll go over that here soon as well. Methods to optimize healing and function. You want to have good gait. Very important. I have a challenge for anybody out there, whether you have hip pain or not. If you go out today and you begin to limp, and just limp for 3, 4, 5 hours, and say, you know what? At the end of that 4 or 5 hours, I bet you're going to have a lot of pain in your hip and in your knee. And that's why one of the main things that I have people work on, whether they're before a hip replacement, after a hip replacement, or not needing one, is an appropriate normal gait. Because our body is like a system of levers and pulleys. And if you're not pulling in the correct direction, we get inflammation and pain. Of course, the muscular pain and triggers, we want to minimize those so that way all the muscles that we've been seeing are minimized. Stretching and strengthening at the end. Because if we have inflamed muscles, we want to wait till they're healed before we start strengthening. In case you don't believe me, after you hit a wall or trip or land on your knee, go do some lifting with whatever body part that is, and then you'll believe me that strengthening should come after the healing phase. The hip replacement, the approaches to it, what you can see is from the front, the side, the back. There are pros and cons to all of them. A lot of folks will do different ones. I myself do 2 of these because I believe 2 out of the 3 of these to be the best. But you always want to make sure you understand that there's no perfect answer, which is why there's so many options out there. I'll tell you, in our national data registries, about 48% of them are done from the front, about 48% of them are done from the posterior lateral, and about 4% from the anterior lateral. And that just trends because there are probably 2 that are superior to the third. Now, why is this important as well? It's because you need to understand afterwards how it affects your rehab, how it affects your stretching, how it affects what you're doing. Because if you don't understand that, if you don't understand the fact that certain approaches may be associated with numb areas, certain approaches might have restrictions, you'll end up and you'll be like, boy, did my doctor even do the correct one? Because you'll be like, is this what I really signed up for? Is this what I want? So it's important to understand these. Now, the post-operative care after a hip replacement, extremely important. And like I said, I think at this point in time, it's important to remember one of my earlier disclosures. This is only one person's view. Now, granted, I have seen a lot of patients. I've done a lot of surgeries. But this is what I found to work best, coupled with the training that I was fortunate to have during my educational career, or educational component of my career. The post-operative care, minimizing inflammation. So anybody that's had a strained muscle understands is that an inflamed muscle hurts. And you're going to have surgery on muscles that are inflamed or muscles already inflamed when you have the surgery. So we want to minimize that. Mobilization. We've discovered, so anybody who might have had a joint replacement 20, 25 years ago, you spent the first week in bed before they got you up and moving. Now, if you've had a joint replacement, you know you're probably going home the same day or the next day at the latest. And the reason for that being is we figured out that mobilization actually helps. It improves recovery. It reduces pain, reduces complications to both heart, blood clots, and the lungs. Also helps with GI complications too. Mobilization in that time period. Precautions and dislocations. There'll be different precautions that you'll have depending upon the approach to the hip, and those will be reviewed with you if you do end up having a hip replacement depending upon the direction or the approach. Safe mobilization, getting up. So, some of the things that I have for my patients afterwards is you got to realize you have to heal and recover. And I always like to use the analogy to football, since we're in football season right now. You'll often see those high-profile receivers going out there week 4, week 5, week 6. All of a sudden they've gone and they have a hamstring injury. And now all of a sudden you're watching them for a couple weeks struggle, and then they're out for 4 to 5 weeks.
Then they come back in week 11, week 12, they play 1 or 2 bad games, and they're out for the rest of the season because of their hamstring injury. Reason being is they didn't give their hamstring enough time to heal. And those are professional athletes with the best, most expansive, most cutting-edge healing treatments that you can have for muscles and tendons. Point being is that in a hip replacement, you're going to have similar injured muscles before you ever get there. You're going to have the surgery, so we need to heal them. So we want to avoid pain after the surgery by not overdoing it. You ease your way back into activity. You slowly increase yourself. Something I often find a little bit comical at times is I'll have people come in at 3 weeks and very often be like, I'm not having too much pain, maybe a little bit of discomfort. Every once in a while, that same person will come in about a month after that, demanding an appointment, just fiery hot at me, so angry. Dr. Eggers, my hip replacement only lasted 4 weeks. What happened? And I'll look at them and I'll be like, well, what have you been doing? And they'll tell me about the one-legged squats that they've been doing on their own, trying to strengthen things up. And then I'll smile, and then I'll ask them to do it with the non-operative side. And then every once in a while, they'll look at me and be like, I got you. Sometimes they'll go to do it and they'll be like, well, that hurts. And then I think the point is made is that, it's a process to recover from these, and that's the post-operative care component to it. Now, as we go through and we look at the post-operative care and the physical therapy with the gait training, there's a lot of things. And with this, a lot of this comes from being able to retrain muscles, our muscle memory. People are like, well, why can't I just walk normal? Well, your muscles haven't walked normal for months to years at this point in time, and your muscle memory is not accurate. Also, you've been constrained in how you can move your muscles with a ball and socket joint that should have free range of motion being locked into place because of your hip problem. So you need to be able to get those muscles to have their normal length, their normal excursion, to then be able to walk normal. And that's often where physical therapy comes into play. So they'll go through things like their daily activities, walking normal, stretching, increasing that mobility, safely going up and down stairs, learning how to transition, and strengthening afterwards. So a big thing and something that I love to reiterate, it's first done with ambulation. So when you get up today, when you go from your seated to standing position, one of the first things you're going to do is you're going to squeeze your core and your buttocks when you stand up. That's actually a strengthening moment. When you get up and you start walking, you're actually having to use all of the major muscles around your hip to stabilize your core and pelvis. Yet another strengthening. So initially after a hip replacement, my bias, of course, is walking. Walking is how you'll strengthen and mobilize while reducing the inflammation. If you go and try and do those one-legged squats, you're going to cause inflammation in muscles that are inflamed. You'll shorten muscle fibers by strengthening them, which then reduces our muscles and how much we want them to get them to move at this point in time. So this is just an example here of a patient 3 weeks after surgery, or a couple folks, people that have had hip replacement.
Will you please give me a...
Here's one gentleman who's 3 weeks out from surgery. You can see him coming down and going up. Now he's definitely a little bit ahead of the curve, but the point being is that he didn't do much beyond the stretching and walking at 3 weeks. He came back and saw me at 3 months, and he hasn't been a very super great patient because he didn't make the follow-up appointments in a year into 3 years, which I recommend for everybody as well for a bunch of different reasons. So in essence, the goal of this talk was to help everybody understand that hip pain isn't isolated just to the joint. It's not isolated just to a hip replacement. There are many factors that contribute to this, many of which can be improved all the way from non-pharmacologic means with stretching, physical therapy, perhaps heat or cold, topical creams, all the way to a hip replacement. And where you fall on the spectrum is hard to know at first, but there are a lot of options out there to try and help maximize your function, your mobility, and your quality of life, which is the whole point of treating hip pain, regardless of the level of the intervention. So I'd like to thank everybody for their time. I'd like to appreciate it. I appreciate everybody being here with us today. Once again, I am John Eggers. That is an email to my group should you have questions. That's a phone number to my office. Of course, the website for North Kansas City, and that is my personal website there as well. These are a few of the references that I used in case you wanted to back check my pictures. And once again, I thank everybody for their attention, everybody's help today in putting this on. and look forward to any questions that we might have.
Thank you very much, Dr. Eggers. We've got a few minutes for questions. Start with the first one from the audience here. Why do you recommend follow-up 3 years after surgery? Great question.
That's a marvelous question. And so a lot of that comes for about 3 primary reasons. Number one, I like to, at least for my patients, I like to evaluate the components. Now, I have some great evidence with the type of components that I use, that even at 15 years, there's minimal wear on the implants. But I like to make sure that that's the case, that there isn't something abnormal going on. For some of those off-brand named implants that are out there, your wear rate can be much quicker than that. And so you need to keep an observation on that because it can affect the quality of the bone surrounding the hip. The second thing is I like to reinforce people that, at least for my patients, I highly recommend lifelong antibiotic prophylaxis anytime you get dental work to reduce the risk for perioperative infection from dental work. And so I like to make sure that we're maintaining that. I also like to make sure people are doing everything that they want to be doing and that they're maximizing the hip function and that there's not anything that they could be doing to better optimize it for themselves. I will tell you after the 3-year mark, it goes a little further out for my follow-ups at that point in time, as long as everything's going as I'd anticipate, and it typically is. Great question.
So another one here, Dr. Eggers. Can hip surgery cause dangerous blood clots?
Absolutely. So it can, and there are great number of studies out there looking at how to best prevent blood clots after surgery while minimizing the risks of creating too much bleeding after a hip replacement or wound healing issues afterwards. And so it'll be specific to patients, but there are quite a few studies on that. But you can most definitely have a blood clot, even with taking all the precautions that one would be prescribed by their treating physician.
Now, here's an interesting question. You used a phrase that kind of caught my attention. You talked about off-brand components. I don't think anybody wants to hear that phrase in regards to a joint replacement, but we had a question, how does someone outside of the medical community make sure that they're receiving the best components with their replacement?
Yeah, fantastic question as well. So some of the things to ask is, what's the longevity of this component? What's the track record behind it? How long has it been around? How did the predecessor to this component perform? Meaning that you don't always want to be the first one to use something and you don't want to be the last, was something that one of my great mentors said to me, and it makes a lot of sense. I know for what I specifically use, and I'm not looking to try and push a brand here, so I'm not going to mention the name, but I can tell you exactly how good the longevity was for all of the predecessors to the components that I now use, along with what was done to modify those to make them even better with advancing technology. You might want to look online to say, has there been a recall for this implant? Have there been complications with this implant? How many people in the country use this implant? Not world, but country, because there are some global implants that are trying to find their way in as well that may or may not be the optimal. Not saying I know definitively, but things to be aware of. Look at the frequency with which it's implanted. Also look at the company that's supporting it. Is this a company that has a good track record and a good background, or is it not? And so it's a lot of information, and if you don't feel comfortable, a second opinion is always an option. Everybody that comes and sees me, I always tell them, if you're not confident in what I'm telling you, or if you're not sure, get a second opinion. There are a lot of excellent hip and knee surgeons in the area. And so I always recommend that they go to one of the folks that I'd recommend for that second opinion. But I always say, if you're not sure, ask another expert. This is going to be your hip that you're going to want to have only one surgery on and be there for the rest of your life. So it's definitely worth perhaps a little bit of background checking. I know it's not the ideal answer because people are probably looking for a list, but it's kind of like going to a mechanic. To an extent, I don't want to trivialize what is happening, but it's really doing your background and looking into it.
Totally makes sense. All right, doctor, one more. Do you recommend playing basketball after someone's gotten a hip replacement?
That's a very funny question. So I will tell you a disclaimer probably from every implant manufacturer will tell you not to do things like basketball, not to do things of that nature for the direct impact loading. I am very patient specific in this and what we talk about and the level and the degree which you play. Different surgeons will have different recommendations. I will just share a little bit of a funny story with you. It's not about hip replacement, it's actually about a knee replacement. And since he's posted it on Facebook, it's no longer a HIPAA thing. But my uncle long ago talked me into doing his knee replacement, and I won't tell you how he did. I felt a little bit uncomfortable at first doing my uncle's knee replacement, but he is a persuasive gentleman, and so got me to do it. And so he always gave me a hard time after his knee replacement. He goes, "Johnny, I lost my jump shot." I'm like, "Uncle Jay, what are you talking about?" And he goes, "I don't have my jump shot." I go, "I haven't seen you jump in 20 years. I used to play basketball with him when I was a kid." He goes, "But the motion, it's gone." And so funny you say that. 6 months after his knee replacement, he calls me. He goes, "Johnny, I went running down the street." And I go, "Jay boy, is everybody okay? What's wrong?" I haven't seen him run in about 25 years. He goes, "Oh, my knee just felt so good. I wanted to see if I could do it." And I go, "Okay." He goes, "I did, but I only made it a block." And I'm like, "Well, did something happen?" He goes, "No, it just takes a lot of work." He goes, "So I stopped." So about 11 months later, he posts on Facebook this just a genuinely wonderful thing. My aunt passes him a basketball, and he's on the basketball court, takes a shot, and he goes, "Johnny, I got my jump shot back." So, not saying that basketball I can't recommend or not. It's a very specific question to probably ask a surgeon, and I'll give you the pros and cons to it if you're a patient of mine, and what I think the highlights are to that for that answer. So not trying to evade your question, but it is very patient specific.
Dr. Eggers, it's been a great conversation. Thank you very much for joining us today. We hope this presentation was informative and helpful for you out there. Be sure to join us Tuesday, February 13th for Rise Above Heart Failure with Dr. James Mitchell, a cardiologist with Meritus Health Cardiology. Again, thanks for joining us. Have a good afternoon.